Welcome, everybody. We're going to give it just a couple of minutes while the people on Zoom are kind of getting into the room. We do have a few housekeeping items. So the session is being recorded today, and we'll put it up on our website in a day or two once everything is finalized. You can access it at concussion.umich.edu. There will be some time for discussion and questions at the end. So for people in the room, you can shout out, but if you're joining us on Zoom, please type your questions into the Q&A section at the bottom of the Zoom window. And then for our clinical providers that are joining us today, we have been approved for CME and Board of Certification Category A credits. So you'll get an email after the session, and you'll have to fill out the survey, and then we'll get you the certificate for your credits. So welcome everybody, or welcome back to the University of Michigan Concussion Center Speaker Series. My name is Steve Brolio. I'm the director of the center, and I'm excited that you're able to spend some time with us today. Over the last 10 or so years, I've been fortunate to get to know some of the best known and well-respected researchers and clinicians and scientists from around the world. So the goal of our speaker series is to bring their knowledge to you, to create a space where we can learn from them and share some of the challenges and the successes that they've had across the year. So I'd like to give a warm welcome and special thanks to our speaker, Dr. Cheryl Wellington. She's a professor in the Department of Pathology and Laboratory Medicine in the Faculty of Medicine at the University of British Columbia. Cheryl's research focuses on 3 genetic environmental risk factors for dementia: ApoE metabolism, history of mild traumatic brain injury, and cerebrovascular dysfunction. Dr. Wellington is internationally recognized for her work on lipid and lipoprotein metabolism in the brain, and her work has made key contributions to the understanding of the role of ApoE4 in Alzheimer's disease. ApoE also plays a crucial role in the repair of damaged neurons after TBI. Her current research projects include drug discovery efforts to increase ApoE function in the brain for an application to both Alzheimer's disease and TBI, understanding how movement of the brain and head after TBI correlates with behavioral and neuropathological outcomes, and tissue engineering approaches to investigate cerebrovascular function in health and disease. Please join me in welcoming Dr. Wellington.
Thank you so much, Steve, for this very warm introduction. And I really want to give a big shout out to the opportunity to be here. The hospitality, the organization of the trip has just been absolutely fantastic, and it's such a pleasure to join you today. So today I'm actually going to be focusing on the newest program in my laboratory, which is really taking a very deep dive into the fluid biomarker space. It's something that started in our lab in around 2016. It's just grown astronomically, and now it is about half of what we do in the lab. So I hope you enjoy this journey into a little bit of, I think, what is really going to be the future of neurology in many cases. And what I would love to be able to do is really set the stage and then have, for anybody that's interested, have some follow-up discussions about potential collaborations that can be envisaged. And if there's any questions that you have for me on how we might be able to guide some of the concussion work that's happening here. So this is the beautiful building that I work out of, the Javad Balafagian Center for Brain Health. It's a translational building. The bottom 2 floors are clinical. We have a 3rd floor for teaching, admin, and dry lab space, and the upper 2 floors are wet lab research. So it's really intentionally designed to be very interactive. And this has brought us into contact with so many clinical teams. I'm a fundamental researcher, a PhD. I'm not a clinician. I don't see patients. But the opportunity now to be able to serve this network of people that we've developed within our fluid biomarker program is just absolutely outstanding. It's a big program, and today I'm really going to focus the talk on the acute section rather than the chronic disease section that we're doing in neurobiomarkers. So use the button. We don't seem to be responsive. Maybe try that. There we go. Okay, so I do have some disclosures, mainly for grant funding. Very grateful to a large variety of funding bodies that supply the money to do our work. What I will do today is to outline a little bit about why fluid biomarkers are such interest in neurological diseases. and really provide some education about the whole discipline of laboratory medicine. Has anybody here taken a lab medicine course? Or had, yeah, most of us are, you know, we're trained in neurology or kinesiology, such fields. And when we really start to drill down on the amount of work it takes to take a laboratory test from a research setting into clinical practice, this is where what we are trying to do is offer our network of clinicians that fund of knowledge and those skill sets. And then to learn about some of the newer technologies that are coming on board. This field is moving at warp speed, and it's really exciting to be in this space right now. So those are the objectives for today. So let's start off with, like, what is a biomarker? So it is something that you can measure that reflects a physiological, pharmacological, or other aspect of a disease process. And it can be used in many different contexts of use. And in order for a biomarker to be used clinically, you need to know who you're using it on, what it's supposed to measure, and what the actionable item of that test result is. So some examples of different kinds of biomarkers include susceptibility or risk factors. So this might include factors when we're thinking about Alzheimer's disease, for example. What could we use to maybe screen for risk of Alzheimer's disease? A diagnostic biomarker is a different type of biomarker. It's meant to tell you whether a disease is, yes, it's present or absent. So it's a binary decision. A prognostic biomarker will give some insight about what will happen to that patient, what will be the disease course. A predictive biomarker really helps a clinician match an intervention to a particular type of patient. A pharmacodynamic biomarker tells you something about what an intervention is doing to the physiology of the person. And there's also safety and monitoring biomarkers. So when you have a biomarker that you think is ready for clinical use, you have to very clearly define what the context is. Is it diagnostic? Is it prognostic? For what's your patient group? Etc. So this is something that is very, very much required by FDA or any of the regulatory bodies. And there's a whole pathway that involves extensive analytical validation and clinical validation to bring a biomarker from a research use only state into clinical utility. This can be a very long and involved process. So for example, the clinicians in the room probably have used troponin. That took about 20 years to go from a very robust, research use only context into clinical practice. So we're at that stage now with many biomarkers, fluid biomarkers that are probably going to be useful for several neurological contexts. And it's such an exciting time. So normally for many neurological diseases, we have a disadvantage in that we don't get a brain biopsy. Compared to oncology or other indications, we don't get the tissue, we don't get the human tissue to study. So we are left with clinical assessments such as cognitive and neuropsychiatric tests, as well as neuroimaging scans to be able to give some insights into the pathophysiology of what is happening to that patient. But there's now the possibility of measuring proteins or other analytes in fluids, cerebrospinal fluid and now blood, that stand to revolutionize how we manage neurological disorders. So this is a game changer. And some of the key markers are listed here. We can measure A betas, we can measure phosphorylated taus, various versions of taus, neurofilament light. Most of us have heard a lot about that, and we'll describe this in great detail. Glial fibrillary acidic protein, and many, many, many others. Up until maybe around a decade ago, it was only possible to quantify these accurately in cerebrospinal fluid, which requires a lumbar puncture. And it's much easier to get a blood test than a lumbar puncture. Patients like it better. But it took the advent of ultra-sensitive technologies to be able to get the accuracy and the sensitivity that require to go to blood. But one of the things, the more removed you get from the brain, the more you have to validate, is this signal in blood really reflecting what's happening in the CNS? And there's still a lot of that work that's going on right now. So blood is a very accessible fluid. what's also important to recognize is that blood testing can help us overcome some of the challenges we have in equitable access to state-of-the-art diagnostics. Not every jurisdiction, not every patient can come get a PET scan, but almost everybody can get a blood sample taken. And there are even some pilot studies in British Columbia, where I live, that are using drones to fly blood samples through, over mountainous areas, for example, to try to speed up getting a blood sample taken and having it measured in a core laboratory. And so like we're really at a great part of the, in the history of what we do with neurological disorders. Now, the first technology that really made this possible was called the Quanterix single molecule array platform. And the way that this works is, does anybody not know what an ELISA is? Do you want me to go through what an immunoassay is? Put up your hands if you'd like me to review that. Yes, okay. So here's your protein of interest and here's an antibody. We're good so far? So in an immunoassay, what you do is you bind your protein of interest with your antibody, and sometimes you have a secondary antibody to amplify the response. But that reaction takes place maybe in 50 microliters or 10 microliters of volume. And you require the signal, whether it's light or a color, to develop sufficiently strongly in that amount of volume that you can detect it by whatever method you're using. That turned out to be insufficiently sensitive to really detect blood, like was below. We couldn't detect it, came up as 0. What the Simoa technology did is to take that reaction volume, say 50 microliters, and spin it out on these arrays of microwells. And each array contains 216,000 little microwells that are femtoliter size in volume. So that whole reaction volume is spread out, and the color reaction or the light reaction takes place in these little bitty wells that are only big enough to have one complex of antibody and protein. So what this technology does is basically convert an analog assay into a digital assay. A well is yes, no, yes, no, yes, no. And that revolutionized the ability to bring down the sensitivity for some analytes by 1,000-fold. And that really started the world in being able to measure brain-derived proteins in the blood. So using this technology, most of the research is done on the Simoa technology to date. At the later part of the talk, I'll introduce some of the other technologies that I think will rival Simoa in the future. But what I'd like to do is to share some of the vignettes of some of the acute disorders that we are using the Simoa technology for. That will include concussion, but I want to show you some other indications as well. So the first one I'm going to talk about is spinal cord injury. It is not such a common injury, but it's probably one of the most expensive neurological injuries to occur, really life-changing for a lot of people. Depending on the level of like where in the spinal cord the damage occurs and the extent of completion of that damage really tells you how that patient is going to do. The text here just gives you some statistics. It used to be that we saw mostly young males getting spinal cord injuries, but now it's a lot more later in life, middle age. And you can see here, the causes are very similar to that obtained by TBI. Now, one of the big challenges in spinal cord injuries is it's kind of shocking to realize that we have not been able to do a clinical trial in spinal cord injury for about 20 years. All of them have either failed or they have not because of efficacy, but because of design challenges. And this is because the clinical exam, the INSCI exam, is really difficult to do, especially if the patient comes in intoxicated or polytrauma and you actually cannot perform the exam. It's not that accurate. It's kind of, some of the surgeons that I speak to, it's like kind of worse than the Glasgow-Coma scale in many ways. And so it's difficult to get a good sort of baseline assessment of how severely injured a patient is. So the clinical exam is impossible to do, and that rules out the eligibility of that patient to undergo a clinical or be eligible for a clinical trial. And then the second problem is that there is some degree of spontaneous recovery after spinal cord injury. There is some amount of healing. And so some patients do recover, say, some motor function, or they move up, like they move to a lesser grade of severity after 6 months or a year. And in the designs, we don't know who's gonna like improve and who is not. And that noise really has made design of trials very, very challenging. And for this, you really can't tell if your intervention is working because those patients might have just been the ones that would have recovered anyway. So it's been impossible to really do good SCI trial work. So we've been working with Brian Kwan, who's probably one of the most internationally renowned spinal cord injury spine surgeons and trialists. So his CAMPER study is looking at the effects of CSF pressure on the outcomes of spinal cord injury. And so he's been able to collect and bank CSF and blood specimens in a very granular way from a number of spinal cord injury patients, as well as controls who were undergoing spinal surgery, a laminectomy, for example, that did not have the spinal cord injury. And so we've been working with him on the biomarkers and the data. I wish we had this clean data for every indication that we have studied. SCI is super clean and super robust. So the first bit of data that I'm going to show is CSF UCHL1. This is a marker in the cerebrospinal fluid of neuronal death. And in the red are the most severely injured patients. So these are Asia A and B grades pooled together. And in the blue are the lesser severe injury patients, the C's and the D's. And you can see here that taking a measurement at 24, 48, 72, or 96 hours after the original injury allowed us to create ROC curves to predict their degree of spontaneous recovery 6 months later in terms of regaining motor, whether they stayed motor complete. So the ones that had higher UCHL1 levels and these levels stayed up more were the ones that remained motor complete by 6 months. But of course, CSF is not that commonly taken after spinal cord injury. So we and many others have validated that blood and CSF levels, neurofilament and GFAP, correlate very well. So we then went on to look at blood, neurofilament, and GFAP. In the blood, UCHL1, even by the Simoa technology in healthy people, is so low that it is very difficult to measure accurately. So we left that one out of the equation. But these are the curves looking at serum, neurofilament on the top, and GFAP on the lower graph. And again, separating patients into those that were motor complete, more severe, A and B, versus incomplete, C and D. And the patients that remained complete were the ones that had higher levels to begin with over the first few days after injury. And the ones that regained motor function were the ones whose GFAP levels started to decrease by 72 and 96 hours. And you can see the ROC curves on the right-hand side where we're getting predictive value of, like close to 95%. So this is outstanding in a sample of about a little over 100 patients. So now this study is going forward to be a multi-site study. The study is unrolling and undergoing right now. And pending the completion of this study, we will probably pose the utility of GFAP and NFL as prognostic biomarkers in spinal cord injury, as well as be able to provide a more accurate baseline severity than the INSCI exam and be eligible for clinical trials. So this is some of the cleanest data that we have. And I also want to make the point that we don't understand the physiology of this because spinal cord volume of tissue is pretty small. And yet the levels got so high in the blood that sometimes we'd have to dilute the sample 300,000 times to bring it in within the assay range. So we actually hit the ceiling level, the upper limit of detection on the assay pretty frequently in this study, and we really don't understand why. Yeah, go ahead, Hank.
Just wanted to ask you, because if you look at the NFL, it goes up over time,
Mhm.
both for the more severe and the less severe. Whereas that's not the case with GFAP, and I don't know if the audience online can hear this, but what does that tell you about the two proteins and
Mhm.
clearance, whatever?
Yes, okay, so I will repeat the question for people on Zoom. Thank you, Hank. So what Hank was asking about is the trajectory. So NFL tends to, it's still increasing in both groups, those who gained motor function versus not, whereas GFAP tends to clear. And what does that really mean about the physiology? What I think is happening is that the neurofilament is starting, because we have the initial injury, right? Either it's a transection, compression, whatever. But we do know in spinal cord injury that that kind of spreads up and down below the level of injury. And I think that's what we're seeing in the neurofilament. Now, the GFAP probably is a little bit of that resolution of the immediate inflammation that happens. But if you have that spreading, that inflammation might be staying up longer than if you don't have that much. So we think, but we have not proven that.
Thanks.
Okay, so spinal cord injury is looking pretty clean. We don't have data anywhere close to this level of, okay, we can really tell in any of the major traumatic brain injury work that we're doing. So severe disease, severe injury looks like it's quite amenable to being able to use biomarkers for prognostic context of use. We're doing also a lot of work with our neurocritical care physicians. Dr. Mip Sagkon is an intensivist who is doing phenomenal work in our intensive care units. Ryan Hoyland is a PhD scientist who's one of the most, exciting new stars in the area of cerebral vascular physiology in acute injury. What's really interesting about our site in Canada is that for a patient that is in the ICU, they will get an arterial line as standard of care. But what we can do in the research study is to thread a second catheter up the jugular vein to the jugular bulb. This means that we're collecting new blood that's coming out of the brain. That's a blood that's immediately exiting the brain. So if you compare the venous level versus the arterial level, you get a gradient. And the higher the venous level is, means that the brain is still releasing active biomarker. So we're really interested in looking at, can we use blood biomarkers to improve neuromonitoring in critical care conditions? Now, typically, the indication that I'll talk about is hypoxic ischemic brain injury, or HIBI for short. We get a lot of this in Canada. So basically, if you get a cardiac arrest, then of course blood is not pumping, your brain is not being perfused, and that's not good. What really controls the outcome of the patient is how much brain function is left after, if you're lucky enough to restart the heart. And in our center, actually, most of the ICU beds with cardiac arrest are from opioid overdoses, not typical cardiac arrests in mid to late life. And the way that we traditionally do the neuromonitoring is by sticking in a probe into the brain tissue where we can measure things like intracranial pressure, the amount of brain tissue oxygenation, et cetera, et cetera. Now, access to that, these bolts is, you need a really highly qualified ICU team. You cannot use them in children. They measure only a little focal area, and so they do have their limitations. And we're working with the critical care team to determine, can we look at blood biomarkers as a proxy of doing invasive neuromonitoring, which would really open things up. And this is an example of one of the studies that we've done. So you can see here, there's a patient with a neuromonitoring probe in. Now, this study was looking at basically answering the question, did the brain tissue did it become re-oxygenated? Did the patient become normoxic if you got the heart started after cardiac arrest? So we had volunteers to do this arterial venous physiology experiment that were, no cardiac arrest. They were just kind of doing this so we could kind of get what the healthy controls look like. And then we knew from the brain bolt that we had two types of HIBI patients. One group regained, they became normoxic. So the diffusion, when we got the heart started, the brain was perfusing, oxygen was diffusing into the brain parenchyma. Those are in the red. So the normoxic patients, they did have a little bit of elevation, but they were far lower than the patients who remained hypoxic. That somehow there was something preventing, even though the brain was being perfused, oxygen was not getting into that brain, and those patients do very poorly. So we've taken this and we've extended to pretty much every biomarker that we've tested has that same pattern. The top is just looking at the bulk levels, and the bottom really shows the arterial venous gradient. And the lower that gradient goes, the more new release of that biomarker is coming out of the brain. So we feel that this approach might really help us improve monitoring on a patient-to-patient basis in the ICU if they have a really acute neurological disorder. And we're also thinking about, well, can you use this during surgery, especially if you're working with babies and pediatric patients? We don't really know, for example, if you're doing heart repair in a baby with congenital heart disease, that baby is born with hypoxic insults. And if you repair that heart, do you normalize that? These questions have never been addressed. So we feel that there's a great future for biomarkers for many contexts of use within critical care, surgery applications as well. Now I'm going to take a little bit of sidestep to explain some of what we're doing now to improve our interpretation of these biomarker studies. And I'm going to talk about something called a reference interval. So who here has had a blood test for anything? Yeah, almost everybody, right? So you can go get your result and you see your number and you see a range, right? And that the physician then interprets, and so do you look at your number, you say, okay, I'm good, I'm in the range, or I'm above or I'm below, right? And that's how basically, the lab medicine aspect works. You have to define those normal ranges. And that's done. There's whole guidance about this by the Clinical and Laboratory Standards Institutes. To enable, how do you generate these reference intervals for any lab test? That's part of the qualification. And then once you have them, can you get away from just comparing, say, control versus injured group or this, and really determine can you use this test just like it would be done clinically? So we have been we've been really trying to do this at the level that would take these to qualification. Now, sometimes a control group, we have to really understand that this is often a convenience control group. So for example, our concussion studies, we are typically taking people at baseline or people that didn't get a concussion or swim errors or what have you. But the problem with that is that the regulatory bodies would not accept that as showing the normal range, because that reference group is not representative of the population at large. You have to go much to a greater extent. The clinical tests have to have a reference range that is based on, and allows you to create standardized cutoffs, and that we'll be able to tell if that sample is within the normal or outside the normal range. So there are sort of two ways that these are being done. One that you've probably seen when you look at your own lab reports, and that uses basically, a discrete, if they give an upper or lower range. And so you basically look at that, you either fit within that or not. There's a newer methodology that's coming on board that uses more continuous methodology. By quantile regression, for example, you can create continuous curves. These are more similar in concept to a pediatric growth chart. And everybody's familiar with that, right? So basically, the 5th and the 90th percentile and the median, and that kind of gives you. So it gives you a lot more precision in assigning a value. Is it 50th? Is it 20th percentile? Is it, way outside in which you would get a Z score, for example? And this is where this field is starting to move to. So we are fortunate in Canada to have available epidemiologically valid studies where blood samples are taken. The Canadian Health Measures Survey is run by Statistics Canada. And every 2 years, 6,000 Canadians, 20,000 sampled, undergo blood testing and a full workup for, for a lot of different demographic, socioeconomic, and health condition variables. There is probably 7,000 data variables in this data set. And so we established, it took 6 years to establish a partnership with Statistics Canada to get through their privacy regulations to be able, to get these samples. And last year we published normative data for the Canadian population for A beta 4042, plasma p-tau 181, neurofilament, and GFAP for the ages spanning age 3 to 79 years of age. Each of these curves, the middle line is the median, 50th percentile, and the upper is the 95th, and the bottom is the 5th percentile. So you can see really interesting patterns here. So the ratio of A beta 42 to 40 dips slightly during aging, probably indicative of some people starting to get amyloid in the brain later. But we know that p-tau 181 and several other p-taus are actually better reporters of amyloid positivity. And you can see here in the geriatric population, a big uptick about after age 60, that the normal levels of p-tau start to rise. We don't know right now whether all of those people have amyloid or whether they are destined for cognitive decline. These are active areas of research. But I'd like you to also appreciate is that at the lower end of the age spectrum, the levels are really high too. And so what does this mean? Is this neurodevelopment? Is this maturation of the BBB or the meningeal lymphatics? Is it simply because kids have big heads to little bodies and it's just simply a mathematical thing? But what this really indicates is that age is a big factor in determining what the cutoffs are. So for example, I'll get to this later, but some of you might have heard about the Abbott ISTAT test that's being used for ruling out the need for head CT after mild traumatic brain injury. It's a one-size-fits-all cutoff. And if you have somebody that's 70 years of age, they're going to test positive. And so this is why, having these sorts of data allow better formulas so that you can plug in what test you did, the age of the patient. Sex was not a variable here. There might be other variables like racial background or socioeconomic status or who knows. And also the type of instrument that the assay was measured on. But what we're working towards is being able to develop the conversion factors that give you percentiles or Z scores for these as a function of these. And that's going to make a world of difference in being able to interpret these tests. And this is a separate study looking at just at the pediatric range, this time in serum, but the data are actually very similar. Kids under 4 are really high, both for NFL and GFAP. And so we're actually really interested now in starting to explore the neurodevelopmental applications of biomarkers. What about autism? What about ADHD? What about other forms of neurodevelopment? What could that mean for later cognitive decline and brain health over the lifespan? So we're in a really exciting time to be able to look at all of this. So now with that background, we have the reference data. That's what we're trying to overlay into the SHRED concussion study. So this is our major sport-related concussion study that we are involved with. So basically, we all know that sport-related concussion right now is really dependent on clinical assessments and the symptom severities and scores that a patient will report on. Most of the action, I think, in the sport-related concussion field has been on the collegiate age athletes. In Canada, Carolyn Emery, who many of you know, she started the SHRED concussion study that is really looking at high school age kids, so age 13 to 18. This is a prospective cohort study enrolling 6,000 high school kids across Canada. Where they have baseline assessments on an annual basis, and then they have their blood sample taken. Not many kids consented to actually the blood sampling part, so we're kind of missing the first, So there's a lot of holes in you know, completion of every or missing data with all of this. But basically, if a participant had a sport-related concussion, then they would get another blood sample within 72 hours, which is a big interval, and that's also a limitation. And then thereafter, until medically cleared to return to play. And so we are running using the Samoa methodology, the usual suspects: total tau, neurofilament, UCHL1, PJAP, GFAP, and p-tau 181 as the first suite of biomarkers. Jason Tabor has been the PhD student, now an MD student, looking at these data. What he found is that at baseline, UCHL1 and GFAP levels were slightly lower in males, and p-tau 181 was slightly higher in males. And similar to what we found in our normative data study, GFAP levels were decreasing by around 6.5% per year over the age range in the study. The other thing that Jason did, which was really, really exceptional, I think this is going to be a big question for how we might need to approach lab medicine in sport-related concussion. And that is because we're at the low level, concussion doesn't really make these markers move very much. We're talking about, does a difference of 1 picogram per mil matter clinically? Now, when you go to get any clinical test, that's not done in duplicate, it's not done in triplet, it's done in singlet. And that means you know, there is going to be some noise, especially at the low end of the assay. Now, in the research setting, we usually do 2 replicates, and there are a couple of ways that people manage this. One, the most common, is just take the average, and that's what you use as your point. Some people basically throw out the samples where they have more than 20% variance between those 2 replicates, et cetera. So there's some questions about what to do here. Jason did a beautiful study where he looked at he used Bland-Altman analysis to look at the agreement between the 2 replicates, and he modeled the data where he included everything, didn't throw everything. And that's using a multi-level regression model. The model 2 was what most studies will do, is take the mean of that measurement. And the third model was throw at everything that has more than 20% CV. And what we found during this is that, look at this is the agreement between 2 replicates. So if you look at GFAP, the Bland-Altman plot really tells you the agreement between the first replicate and the second replicate. So the bigger that spread in the data, the more the replicants are far from each other. So if you look at GFAP, when you add up the upper and lower spread, you end up with a range of almost 36 picograms per mil that is just noise from replicant assessments. When we consider that a lot of concussion studies are reporting an increase 2 picograms per mil after sport-related concussion, we can say, well, this might be noise. We still need to look at that much more closely. UCHL1 was similarly high. NFL was pretty tight. p-tau 181 was pretty tight. But we need to do much better in managing replicate error and really understanding from the analytical performance of the assay, is it good enough to take forward and really help us interpret these data? So basically, we're now taking a look at quite a few studies to determine, can we do better if we include all the data and use these multi-level regression to improve precision. We know that if we took the method of throwing away anything without the 20% cutoffs, this really changed effect size, and some associations were no longer significant. So this is not standard for clinical lab medicine. So we might need, for concussion in particular, a whole revamping of how clinicians use a test. And that might have cost implications and so on and so forth. So he also, we've started looking at post-concussion in the SHRED study. And so we binned samples into post-injury day 0 to 3, 4 to 10, 11 to 28, and beyond 1 month after injury. And this is kind of what the data look like. And so, yes, we can pull apart some statistically significant differences between biomarker levels, but sometimes they go down like t-tau and sometimes an NFL, and sometimes they're higher like GFAP. And it's a bit of a challenge to kind of understand this from a physiological perspective. And then the effect sizes are very, very, very small. So again, when I talk with my clinician colleagues like Roger Zemek, and we still, we have a lot of friendly discussions that, okay, Cheryl, you have to prove to me that a test is robust, has a big enough effect size that it's going to be better than my clinical assessment. I think we still have some work to do with these biomarkers for concussion, at least in the high school kids. Now, one of the other things that we're doing is now that we have the reference interval data, that we did for the population norms, and those meet criteria for being used. Can we compare our shred data against this? And what I want to comment on here is that for those of you who are running Simoa assays, it's really important to be on top of how Quanterix is continually changing the assay formats. You can choose to run it NFL by itself or NFL in combination with a bunch of other things. But the assay that you choose matters because sometimes the antibody is different, the dynamic range is different in the assays, and you have to prove that you know the association or whether there was bias in one assay format versus another. So we're starting to do this cross-lot analysis now. So you can see on the upper part, the correlations are really, really good. But if you look at, say the third bar in the right, you see a real strong negative skew, a 23% bias on assays that were run on one format versus another. So that means if we do something like overlay our shred concussion data on top of the normative data for the age range and the Canadian population that these participants are drawn from, we have not yet done the corrections, but this is an example of where we're going with some of these data. But at face value, a lot of these participants, they fall pretty much within the normal range. These are the baselines. There are a few that are outliers, and we don't have any explanation why they're a little bit wonky. But the cross-assay data suggests that our shred data are going to be skewed to be a little bit lower. But still, even if we make that adjustment, and we still need to do that formally, it's likely to be still largely within the normal range. And this is baseline. What about post-concussion? So this is the post-concussion data. Again, mostly still within the normal range. And so we still need to do the adjustment. The hope might be that we might be able to arrive at, well, if you're absolutely normal, you should be 50th percentile. But what if what counts in concussion is moving up to 70th percentile? You're still in the range, but you're crossing percentiles. That might be just like how we use pediatric growth charts, the way that these tests need to be done clinically for concussion. So within the next year, we will be able to provide that guidance and kind of reinterpret the data that we have collected for sport-related concussion work. So basically, the conclusion from the shred work that we've done so far is that almost all of our samples are within the normal range for high school kids. The assay counts, there is skew in the data, so you really need to be on top of what you're measuring. And that the effect size is very, very small. So we will be challenged by the clinicians to really prove, are these going to be useful, especially for the cost of running these assays? Or are these not the right markers? Could there be different markers that we're not looking at? Or could it be that the clinical symptoms are not explained by the physiological changes that go to release NFL and GFAP? And that we're, from a physiological perspective, the neuronal health, the axonal integrity is pretty good after a concussion in these kids. We don't know the answers to this yet. Okay, I'm going to move now to a sensitive topic. And so if anybody is triggered by this next discussion, feel free to leave the room. I'm available to debrief after, but I'm going to talk about intimate partner violence. And this is an area that we are starting to get very deeply involved in. So intimate partner violence is a gender-based violence, overwhelmingly affects women. And both the World Health Organization and CDC have statistics that 1 in 3 women worldwide will have at least one experience of violence at the hands of a partner. In the clinics that we're working with, a lot of young people, so girls between 15 and 25 are a big peak in age. The rate of IPV is even higher in marginalized, racialized women and associated with more severe violence. And so we're now starting to ask, is there brain damage from IPV? Does this look like concussion? Does it look like something else? And a lot of, we know, like, if this is true, like, this is huge for women. And we also know that Alzheimer's disease is more common in women than men, but nobody has really asked, is there any attributable risk for Alzheimer's disease or cognitive decline or any kind of neurodegeneration in women that is caused by this? Now, it's different, I think, than straight TBI or mechanical concussion as we would see in sports, because the impacts can be there. Women are shoved, pushed down the stairs, their heads are thrown against a wall. But even more common than this is that they experience what they call choking, but the technical term is non-fatal strangulation. So this is pressure on the jugular vein and carotid arteries that will disrupt blood flow to the brain, increase ICP. And what's really amazing to learn is that the average male handshake is enough to constrict the jugular veins, no problem. So you don't need much pressure. And some of the women that we're working in the clinics that we're working with report that they're choked to unconsciousness several times a week in their relationship. This is not good for the brain. Okay, so there's been a few studies looking at this. So this is a study actually from Donald Weaver in Canada that in a study that he published, 17% of patients with Alzheimer's disease reported a history of IPB with head trauma. But we're not routinely asking for this. And I asked you this today, do you ask about this? And it's very spotty at best. Or the clinicians in the room, if you're working with an Alzheimer's disease patient, do you feel that you have the training to be able to elicit an honest answer, especially if they come in with their partner? How do you do this, right? And so it's not an easy thing to discuss. There has been one study that suggested that there was CTE, a single case study. But Kirsten Dams O'Connor published a study of 84 women, actually, pathology study. And what she found was only one case had proteinopathy, but almost all of the cases had vascular injury that looks very similar to what Julie Schneider publishes in her, in her vascular contributions to dementia studies. So we really don't know what the ultimate neuropathology is of this. One of our collaborators, Sandy Schultz, used to be in Monash in Australia, now in Canada. This is one of his figures from the emergency room, looking at healthy controls, trauma controls, mild TBI patients, and IPV patients, looking at neurofilament. And just like we can't find much of an uptick in neurofilament in concussion, or our study also in mild TBI is like this, the IPV patients come in with higher NfLs. And the NfLs that we're looking at would be consistent with a moderate brain injury. So we've started a study with a dedicated clinic in British Columbia that has about 30 years of history looking at these patients, including developing a very unique strangulation clinic that is world-renowned and disseminating a lot of this information. And so we're able to separate a participant into, say, emotional or sexual abuse, head trauma alone, strangulation or alone, or both in our study. And we have just been funded by the US Department of Defense to look at blood-based biomarkers, and I'll show you some very, very preliminary results from the first few patients. So we have 29 acute patients that have come in within 10 days or so to the clinic. And then from a separate site, we're looking at a small number of chronic participants. These are women recruited from women's shelters who have left a violent relationship, and they have consented to participate in the study. We have a huge case report form, and we're really debating how close we need to be to the ACRM criteria for this study. Because some of the questions on that criteria, were you more upset than usual? Well, yes, they've just been beat up. And so it's some of the questions are just not relevant, and our nurse practitioners will not ask them because it just doesn't make any sense. But we're very happy to share where we are on this unique type of case report form. And here's the levels. These are on the same lots. And so this is really, so here's our levels overlaid with the reference range across the age range. So you can see here that there's several cases with quite high NFL levels. GFAP was surprisingly, to me, mostly within the normal range. And there were some cases that were trending toward the lower levels of A beta. And I'm going to point out just a few interesting case studies. So these are markers that are sort of outside the reference range, or very close to it. They don't coordinate. They don't So if for example, if you have a high NFL, doesn't mean you're going to have an abnormal GFAP or A beta. But I'm going to point out this one case here. So this is a woman in her late 30s. What brought her into the clinic was a case of non-fatal strangulation with loss of consciousness 20 days before the blood draw. She has an extensive history of IPV with head impact and strangulation over 7 years. And her GFAP and NFL levels are above the 95th percentile. And her A beta levels in her 30s are below the 5th percentile. So for me, this would be a case of concern. I would like to have a more extensive follow-up on this patient. And if somebody like this came into your memory clinic, what would you think, right? With biomarkers like this, most AD-oriented researchers would not be thinking about what happened to that person before they showed up at the clinic. There's another case here. This is a female in her late 20s. She had both head impact and non-fatal strangulation in the most recent incident, and her NFL levels are super high, but her GFAP and A beta is pretty much normal. So we don't really know what that means. But I think what we're seeing in even a small number of IPV cases is that they have more robust biomarker changes than the typical sport-related concussion changes. So that's also something just to consider as well. So we're really lucky to have a new DoD grant that will allow us to go up to 500 participants. And what we're going to do here is a panel of 120 neurological and 250 inflammatory markers. Sorry for the typo. And I want to point out here some longitudinal challenges that we have. When we think about ADRD studies or other concussion-like studies, it's like, okay, you take your baseline, you come in after your concussion, we'll see you 6 months later, we might do some neuroimaging. For this population, I have been humbled by the ethics of this. Because if some of these people are living with a violent partner, even having an appointment in their calendar or might alert their partner that they're seeking medical attention, God forbid, and that could contribute to more violence. So we have to work really closely with our ethics committee to how do we do this? How do we communicate? So our information, for example, is coded. Like we give out, say, a gift card, and that number on the card is the phone number of the clinic, but it's organized in a way that you'd never know it was a phone number. So right now, we are not yet at the stage where we can kind of call people back for longitudinal assessments. And so we're struggling with this. And plus, the no-show rate tends to be around 30%, which means it's hard to staff a clinic appropriately. So that's where we are on some of our acute studies. I just want to highlight in the last few minutes a bit of the infrastructure that is coming on board and that we are happy to share our experience with and open to collaborations. So all of this work has been done on the Simoa platform, and in my lab we have 2 HDXs and an SPX. The SPX, the smaller machine, is usually used to run multiplex cytokine analyses because they can't be run on a larger machine. We are working with the iStat device mainly for spinal cord injury and HIBI rather than TBI, because we know that the results are super, super strong. And so we're really determining, can we use these point of care devices to determine, for example, If you have a spinal cord injury patient, and you need to transport that patient for surgery or to another hospital, can you use this test to help you organize that priority and call in the helicopter for transport? Or can that patient wait or be treated at their closest hospital? We are in the process of building a core facility at UBC Hospital where we will have a dedicated space where we'll bring on 2 clinical grade instruments that are dedicated for research and will be able to be run clinically as well. So we're going to bring on a Roche and a Fuji Rebio platform. The Roche is in high use in North American hospital labs, Fuji Rebio not so much in North America, but highly used clinically in Europe. They have very robust platforms. Now they're new on the market for neurological assays. And so we're going to need to do a lot of analytical validation here. But this then allows us access to clinical grade instruments that would be the same as what is in a hospital lab. So for example, things like neurofilament light for multiple sclerosis, which is already used clinically in Europe, we can do the studies on the same instruments that would be run clinically. We're also going to be bringing in the Alamar platform. So some of you might have heard of Olink. Alamar is a very similar kind of platform, but it's got a little bit better sensitivity and it's got a real focus on CNS. So the way this assay works is a double capture and release mechanism, which gets rid of all of the noise in a signal. And then, because it uses 2 antibodies with a bit of DNA, then what you do to evaluate the assay is to ligate those DNA strands in either PCR or next-gen sequence up the measurement, and it gives you a number that tells you the concentration of a biomarker. The platform for Alzheimer's disease markers is looking really good, on par with C2N diagnostics and the Lilly assay. So it's looking very, very good in these round robin assays that have been conducted so far. And they offer panels. The CNS panel includes about 120 markers. It includes A-betas, all the p-taus, NFL, neurofilament heavy as well, GFAP, UCHL1, and a number of other markers, and a very extensive inflammation panel that includes a lot of markers that might be relevant to what is happening in the meningeal system. So we're super excited. We should be on board with this technology by the summer, and we're very happy to share our experience or collaborate with people to run on the panel. So we have an amazing team, and we've been able to accumulate about $30 million of funding so far with this program over the years that we've been operational. And we've been publishing like crazy, and we just really want to open up this core and make it completely agnostic to what neurological indication that we're doing, but help support clinicians and clinical teams in being able to get good quality data with the guidance of people who really know the discipline of lab medicine and clinical chemistry, so that we can do better at bringing things from research into clinical use. And with that, I will thank our collaborators and our funders and answer any questions. Thank you so much.
Okay, just a couple minutes for some questions. I will open it up to the audience. Or I can start. There's one that came through Zoom. Are biomarker profiles consistent 6 months after discharge from hospital?
For which indication?
They don't say.
Okay. Well, so if it's like the spinal cord injury project, they are in hospital and then they're brought back, they're discharged, after. Typically, they're in the rehab hospital for many months, but we'll measure, we have not measured the biomarkers after 6 months. We've just done the acute level. Yep. Yeah.
Thanks for that great talk. And you really pointed out some of the challenges of single point analysis of an individual of a certain age with a certain context in their life. And your data with the spinal cord injury showed quite nicely this trajectory, this longitudinal trajectory over a matter of days. Do you envision we do that in a way that could be helpful? Let's imagine the 75-year-old who comes into the hospital with a traumatic injury. We have difficulty piecing out how much the NFL is due to their concurrent
Mhm.
Alzheimer's or their vascular disease, and how much is due to their acute injury,
Mhm.
and following them over the next 3 or 4 days to see the extent to which there's a recovery. Do you have a sense for that?
I think that having a delta, a change, are they stable, are they not, is a really critical question. And it could be that it's the delta that is the clinic, the meaningful result that you want. So I think absolutely yes. I think a lot of certainly, chronic studies like MS, ADRD, they take on one time point and maybe a year or two later you see them again. So I think we can learn a lot with these acute injuries, and especially if we're looking at geriatric falls, and we will learn a lot there to determine, do they spike up and then stay elevated, or just super slow return to baseline and what that looks like. So looking at a lot of intersections of acute injury layered in with the chronic trajectories, that there was ultimately going to be a lot of work there that needs to be done there.
So in a similar kind of complementary way, I could see kind of over time, obviously with that older adult population, finding those reference ranges, I'm sure is a huge challenge because, plenty of people will never get diagnosed with ADRD or other dementias. And so you could be kind of seeing that conflating some of those reference bands as well and everything. And so could you similarly see some utility in kind of longitudinal monitoring of those over years or things like that, to be monitoring similar levels of kind of more longer term injury predisposition in those populations?
Absolutely. So we're taking two approaches to that question. So we are in a lot of discussion with the Canadian Longitudinal Study of Aging. 40,000 people enroll at age 40, followed every 4 years, going up to age 80. And so we've got like 150,000 specimens in the bank right now. We're going to need several $1 million just to buy the kits to do all these biomarkers, but that's going to be one thing that we can do. And then we have it's not a huge, there's no imaging and there's minimal cognitive data on that set. So that's one thing. The other thing that we've done though is work with super seniors. So these are people over 85 that are pristine, they have no cancer, no cardiovascular, no dementia, no cognitive complaints. And you know what? A lot of their biomarkers are still within, like they're not necessarily low. So what does that mean? I don't know. So there's a lot, like there are a lot of nuances to be able to really take this toward clinical utility.
We'll be a little mindful of time because we're past the hour.
So
but-
sorry.
No,
Yeah,
no, totally
yeah.
fine. But thank you very much. I appreciate all the knowledge you shared with us today.
Thank you so much.
Here's a nice little.
How are you doing?
Good, how are you? Good. Enjoying the summer weather or spring weather. I
Yeah, I
guess.
would say, yeah,